Good morning to all of you. I'll be talking about best disease and adult onset vitiligo macular disorders. We don't know why these disorders have some affinity towards macula. It may be because of its anatomical structure or the composition of the choriocapillaries and the type of blood flow it has, and maybe this area is exposed to more light compared to the other part of the retina. So when a patient presents with, like already the previous speakers have spoken that in the OPD they will be having mild blurring of vision, we may just do a refraction and send them back without having a look at the retina. Even that is why the importance of at least undilated fundus examination of a screening of the disc and macula is very important, whoever comes to your OPD, so that we don't miss out on these disorders. So the patient comes with mild diminution of vision, and the examination is showing some mild changes in the macula. So we will just leave it like that. It may be just nothing very significant in this patient. But when you go into the detail, then she might or he will say that there is a family history. One of his relative or mother, father, somebody is diagnosed as age-related macular degeneration, taking treatment for that. So then that will be a stimulus for you to think, is this patient having something else? Because just because of one mutation in a gene, it can cause so many different patterns of disease, ranging from retinitis pigmentosa on one side to the macular dystrophy in the other end. So these are autosomal dominant disorders, and as I all said, there will be, when you have this puzzling fundus pictures, you should always go into a detailed history taking. But other things which should be kept in mind is we have to rule out any kind of drug toxicity. That's why again the history taking is important. History of any infections like toxoplasma and all, they already spoken, and autoimmune disorders, that also we have to rule out, and sometimes even multifocal choroiditis can have this kind of a presentation. So let's talk about best macular dystrophy. There are more than 200 mutations which have been described in that, and it collectively known as bestrophinopathy. It varies from best vitiliform macular dystrophy to retinitis pigmentosa. It's caused by mutation in the BEST1 gene, and when the patient comes with this type of classical picture, we don't tend to miss it. It's very easy to say that there is an egg yolk appearance on the macula, and this is the patient is having BEST disease. But sometimes they can present in the later age group, maybe even at as late as the 60th or 7th decade. That's the time we might get confused with other diagnoses like CNVM in these patients. Usually these have bilateral representations, but sometimes the stage of presentation may be as pseudohypopion or a subretinal or sub-RP fibrosis or as RP atrophy, and even as complication as a CNVM. These are the various stages. I don't want to go into the details. The most common loss of vision in these patients are due to the CNVM. Otherwise, they all have an ambulatory vision. They are able to carry out their day-to-day activities without much of issues. There is an important role of other investigative modalities in these patients, like all other conditions we had discussed previously. FFA and OCT plays an important role to diagnose when there is a confusion in the when you see the clinical picture and it is not fitting into any of the diagnosis. And we can confuse these cases sometimes even with PD or a classic CNVM, because that, like the previous speaker has shown you, the one case it had presented with that fibrotic pillar, so that you can mistake it for a CNVM complex. So these are the few pictures of BEST disease which we had seen. In that, the importance of FFA I am saying, because when you do the angiography, it shows a hyper fluorescence, and in the center you can have this because of the pooling of the dye which is happening there, and because of the window defect, because RP atrophy is there, and that is causing the window defect. And this is the FAF of the same patient, which showing hyper autofluorescence in the periphery, and there will be a hypo in the center. Again, the peripheral hyperfluorescence is due to the lipofuscin deposits which is happening in the peripheral area, and the center hypo is due to the RP atrophy. Yes, EOG comes to play when we have a suspicion in the diagnosis. Otherwise, usually clinically and with these modalities, we will be able to come to a correct diagnosis. This is another patient who had presented in the vitalo-eruptive stage. You can see a scarring in the left eye, and this is the FAF again, the peripheral area showing hyper autofluorescence, and you can see because of the atrophy, the scarring, there is a center hyperfluorescent in this patient. And this is the same patient's OCT. Like in this, you can see that the elevated lesion, and sometimes we can take this for a CNVM complex. This is another patient who's came to us in the atrophic stage. Again, you can take it as a dry AMD in the advanced stage, and you can see this area there is a gross RP atrophy which is more prominent in the left eye than the right eye, and is causing foveal thinning and the scarring on the RP complex, and there is loss of the photoreceptors also. So these patients can have very reduced vision. What are the differential diagnoses that can come to you when you see this patient, these patients at the first time? One is subretinal granuloma. Usually these patients have other features of inflammation, so that unlikely we tend to miss or mistake this with the granulomas. The other one is, as I already spoken, wet age-related macular degeneration. That is in the advanced stage when there is a scarring. But the scarring which is happening, that is the disciform scarring in ARMD, that causes, it has an irregular margin, and then it is not that typical yellow and a smooth appearance as we see in the Best disease. This is another thing, acute exudative vitelliform maculopathy. This is reported in a few patients now, and you can see that there are multiple lesions, and which is seen in the OCT also. This is seen as a component of a paraneoplastic syndrome, and then patients who have taken chemotherapy, they have presented with this. Then fundus flavimaculatus, and sometimes even large dehemoglobinized subretinal hemorrhage can be mistaken for a Best disease. But usually that is unilateral, whereas Best disease have bilateral presentation. CSR and adult onset vitelliform macular dystrophies are to be kept in mind. A word about adult onset foveal vitelliform dystrophies is as by the GAS, and these also have similar pictures. These are a few cases. This was a 51-year-old male. He came with blurring of vision, and his vision was 20 by 20 in the right eye and 20 by 22 in the left eye. Anterior segment was unremarkable. And this is the fundus examination. You can see there were some few drusen's were there, and subretinal deposits was seen in the fundus picture, and the FAF it was showing hyperautofluorescence in the fovea, and FFA was not showing much of a leakage, mild window defect was there, and this is the OCT. It's showing a subfoveal lesion in both the eyes, and which was more in the subretinal location. I followed up this patient. I am seeing him last 2 years, and there is not much deterioration in the vision, and no changes in the fundus picture. This is another case. Again, vision is 6 by 6, and he has a small lesion. When you look closely at the fovea, you can see that. And in the left eye, there is an atrophy surrounded by yellow ring. Again, OCT was showing RP irregularities, and I have not given him any treatment, and he is on regular follow-up. This is similar case. He has vision of 20 by 25, and again the macula is showing some vitelliform changes with RP atrophy, and this is the OCT pictures, an old image, and he has vitelliform changes with good preservance of his vision. There is no definite management of these patients. We have to screen them for development of CNVM, and if they develop, then anti-VEGFs can be given. These are the various complications, varies from sub-RP atrophy to fibrosis to CNVM, or sometime foveal thinning and macular holes can develop. To conclude, multimodal imaging play an important role in these patients, because sometimes just by an angiography or OCT we may not be able to reach a definitive diagnosis. OCTA plays a major role in such patients, and we need to keep them on regular follow-up, so that if secondary complications like a CNVM occurs, we need to intervene. Thank you for your patient hearing.